everyone, and thanks for joining us for our webinar today on advanced care planning. My name is Lindsay, and I'll be your host. And today we have some guest speakers. So our first guest speaker is Liz Baxter, our CEO, and she'll be starting with an introduction and a land acknowledgement statement. And then we'll go into part one, which is sharing your wishes, how to create an advanced care directive with Hillary Walker from Peace Health. And the second part will be with Marie Eaton, who will provide a local perspective and story on her work with Northwest Life Passages and partnering with Peace Health in Whatcom County, and how others might be able to be partners in their counties and advance this work. So we'll get started. Liz Baxter, our CEO.
Good day. This is a topic that's incredibly important to me, both from a professional and a personal standpoint. So glad that we're able to do this webinar and have these really great panelists to join us. Our office, for those who don't know, sits in Bellingham, which is the traditional homelands of both Lummi and Nooksack. And so just wanted to mention that because this place is pretty special with its kind of knowledge and resources. And our team and our board has adopted a land acknowledgement statement. So I'm going to read that to help us get kind of grounded in our space and place before we go on to the work. We begin by acknowledging with humility that the land where we are today is the territory of the people of the Salish Sea. Their presence is imbued in the waterways, shorelines, valleys, and mountains of the traditional homelands of the Coast Salish people since time immemorial. So, you know, when I think about the work and kind of the topic for this call, I start in kind of a very tangible place. One is that the work that we're doing under the Medicaid Transformation Project actually had a very tiny piece embedded in it that we were somehow going to expand the use of the post form across the region. And, you know, it seems very tiny until you realize kind of the construct and the context within which documents like that typically kind of come into a conversation. In the last 10 years, I've lost both of my parents, and so how to structure those conversations and to actually end up with documents where I, as their healthcare power of attorney, knew exactly what their wishes were, that their providers knew what their wishes were, that they felt like people were actually doing things kind of in the best intention of what they would have wanted, is a process. It's not a checkbox kind of a thing. And it's easier to have those conversations when you're not in a crisis situation and when you actually have the ability to think through some of the, you know, like, what if this happened? What might you want to do? From the work that I have been a part of, primarily in Oregon, where I still sit on the board for Oregon Health Decisions, which oversees the advanced directive work in the state of Oregon. There has been a lot of work with patients and caregivers over the last 20 years to try and put some of these discussions in a context where folks feel like they have enough information before they actually have a form put in front of them asking them to sign and let their wishes be known. And for me, the biggest conversation I've had with caregivers, you know, really over the last 20 years is a fear of losing control. And the irony in that is completing an advanced directive and being able to talk to your providers actually gives you the ultimate control over the kinds of decisions that'll be made when you cannot speak for yourself, and what, you know, things might happen for you and about you when you're not able to do that. So, you know, as I am hoping that these two speakers will share, it's just really helpful for us to think about how we can support, you know, and I think again of this in two scenarios. One is, how do we support our providers, our staff who are working with patients and families? How do we support that kind of work? But I'd also encourage us, to think of ourselves as individuals who are also in those same situations and how we might approach that in our own daily lives as well. So Hillary and Marie, thank you so much for joining us, and I will turn it over to you all to lead us through some information.
Great, thank you so much, Liz. And just a couple reminders before we get started on part one with Hillary Walker. Your lines will remain muted throughout the webinar. We do welcome and encourage your questions, so please feel free to send those in using the Zoom chat box, and we'll address them at the end of the webinar after both speakers have had a chance to talk. And then this recording, along with resources presented in this webinar, will be posted on the partner portal, and all participants on this call will also follow up with a follow-up email with those resources and a link to this recording. Alrighty. So now I'm going to move on to introduce part one, sharing your wishes. Hillary Walker will be presenting this, and she's the program coordinator for advanced care planning at the Peace Health Northwest Network. All right, and I'm going to pass it over to Hillary now.
Hi, this is Hillary. Are you able to hear me?
Yes.
Yes.
Great. Thank you so much for having me on this call, and thank you, Liz, for that introduction and your story. It ties in very much with the work that we're doing. And you'll hear me touching on a lot of the things that you already spoke about. So we've already started off on the same page, which I greatly appreciate. So for those of you who don't know, the Peace Health Northwest Network touches in on Whatcom County, Skagit County with the Hospital United General in Cedar-Woolley, as well as Peace Island Hospital out in the San Juan Islands. So this work that we're doing within Peace Health and collaborating with our surrounding communities touches many of the counties where you're already working. So just to give a little bit more information from how I came into this work, which I think is helpful sometimes, is that I was trained as a geriatric occupational therapist and worked in acute care and ICU settings for 15 years or more, and really learned firsthand a lot of what you were speaking about, Liz, as far as how valuable it is for these conversations to be happening well in advance of emergent situations. And really, in my experience, finding out how little education is offered, not only within our communities, but also to providers and caregivers, and that there was really a huge need for creating some collaboration and working on making sure that we as caregivers and people working in the medical system have the correct information that we can share with our communities, and that our communities are getting consistent information from their doctors, their churches, their YMCAs, their senior centers, because that's part of the challenge, is given lots of conflicting information. And so I'm incredibly grateful to be in this position at Peace Health. I am the first advanced care planning program coordinator at Peace Health, and I started about 2 years ago, and since then we now have 3 other program coordinators across the system in Longview, Vancouver, and Oregon. Thank goodness, because we have a lot of work to do. I also sit on the Washington End of Life Care Coalition, as well as the statewide POLST task force. So I love the opportunity to build a bridge between what's happening at the statewide level, how it's affecting our medical systems and communities, and bringing that information back into the counties that we serve, and keeping that connection has been really important. So I know there's varying experiences and understandings of advanced care planning on the call, from what I understand. So I'm just going to give a really broad overview of how I present advanced care planning when I'm speaking to the community. And then I'll dive in a little bit deeper at the end on how we bring this back into our medical systems. So we'll be talking just about discovering advanced care planning, why it's important, which probably many of you are aware of, how important it is to reflect on our values and personal beliefs when we're talking about advanced care planning. So just as you said, Liz, that the conversation happening before completing documents is essential, that we need to really meet patients where they are and understand what is it that they're wanting to speak to, and then how can we help them translate that into a document rather than starting with the document and then trying to interpret it down the road. Talking about how selecting your healthcare agent or your healthcare decision maker is the most important decision that you need to consider when talking about advanced care planning. How to then express your wishes into a legal document. And a big part of our education is then what? Once you have the document completed or have had that conversation, how do you share that information? Where do you store the documents so that they can be easily accessed, easily accessible when needed down the road? So a big part of our conversation when we're speaking in the community is why advanced care planning? Why is this so important, and why are we spending so many resources on elevating this work? So 82% of people say that it's important to put their wishes in writing, but across nationally, about 23% of people have actually done this. Even in Whatcom County, where we have been doing a lot of work around advanced care planning for many, many years, of all patients seen at Peace Health within the last year, approximately 25% of our patients have an advanced care planning document on file. So again, we have a lot of work to do. If so many people know that it's important, we'll talk a little bit later on why people aren't doing it. So another thing that we focus on is that 70% of people prefer to spend their last days of life at home. When this study came out, 70% of people were dying in long-term care facilities and hospitals. This is changing, and we're starting to tip the scale in the other direction. And a lot of that we believe is related to advanced care planning and really goals of care conversations happening sooner than later. People spend less time in the hospital at end of life with less aggressive and non-beneficial treatment when they participate in advanced care planning. And recent studies actually show that people who participate in advanced care planning actually live longer. That is related to the likelihood of potentially not going for more aggressive care when we're having a goals of care conversation rather than a treat conversation. Increased use of hospice services, so people were normalizing the conversation around death and dying and end of life, and really having the opportunity to educate more about palliative care and hospice. And a huge piece is decreased sense of guilt and doubt in families when they're needing to make decisions for their loved ones. With advanced care planning having happened in advance, there's really a sense of really partnering with the person who is unable to speak for themselves, and the people who are sitting at the bedside are actually able to step in as the voice for that person rather than having to make decisions. And that's a huge benefit of this work. So why aren't people doing it? This is a big thing we talk to a lot of caregivers about, providers, communities. First of all, talking about end of life is not easy. We're creating a huge cultural shift in this advanced care planning work by normalizing the conversation around death and dying, working with a lot of providers to understand that death is not a failure, that most patients, again, want to know the reality of the situations that they're in. And so this is an uncomfortable conversation for lots of people, including providers. So when we're talking to our community, we say, you might need to bring it up with your doctor. You might need to say, what if I don't treat this? What if my priority is such and such? Is this in alignment with that? That a lot of this movement is really happening from the community. And then the providers and the caregivers were doing a lot of training to catch them up to feeling more comfortable with these conversations. Another barrier is there are many documents being used in Washington State, as many of you are probably aware. You spoke, Liz, about your work in Oregon. Oregon has one state document, not to say that others aren't used, but that's super helpful that they've landed on that. Some people love it, some people don't. The document itself, I mean. But just when I started teaching in Whatcom County, Skagit County, and San Juan before my job at Peace Health, there were 8 different documents being taught to in all of these communities. And it's no wonder that people get confused. So a big part of our work is really starting to create some collaboration around the documents that we're using. We're working in collaboration with Honoring Choices Pacific Northwest, the statewide initiative that is run by the folks at the Washington State Medical Association and Hospital Association, and really trying to create some consistency across the state in the education that we're using, as well as the resources and forms. People often believe that they need a lawyer to do this work, so that's a big part of our work, is to really normalize this conversation, make it accessible, make this information easy to understand. I can't tell you how many times people have come to one of our classes or seminars and said, thank you so much for taking a really scary subject and making it easy to understand. We are working a lot with our legal partners to make sure that we're all on the same page, and again, that we're collaborating, that we're not working against each other, but really understanding that these conversations, when it comes to medical directives and durable power of attorney for healthcare, these conversations are often best suited to be had with people who are in the medical system and understand, what do we need to understand about you? So I often open this up to what else you tell us. We'll come to that at the end. I'd love to hear other barriers of why people aren't having these conversations. One thing I'll just say to this group that you're probably aware of is that most of our documents are only in English. That is a huge barrier, and something that we're working on at the statewide level, and really hope to see some nice movement around that in this year, 2020. So the 3 decisions that we talk about that really affect your plan are who will be your healthcare decision maker or your healthcare agent. That's usually what we spend most of our time talking with people about, how important that decision is. And then the second thing that you'll see is something that you will not see on any legal documents, and even most advanced directives, including the most widely used document in Washington State, which is the Washington State Medical Association document, does not ask this question. What cultural, spiritual, and personal beliefs do you have that might impact your decisions, and what would be important for other people to know? And really encouraging people to have a personal value statement, and starting there before having the conversation about CPR or tube feeding or, you know, the variety of medical things that can come up in emergent situations. Because as Liz pointed out earlier, no document could cover every situation. It's just not possible. So if we're coming from that really curiosity, what do you believe in? What do you value? And how can we make decisions based on that? And then the third piece is, what healthcare would you like to receive in certain medical situations? And that does dive a little bit into, if you were in this scenario, would you want advanced medical treatment or life-sustaining treatment, and what might that look like? So choosing a healthcare agent, as I've said many times, is really the most important decision, and helping people really understand who they can choose. So quite often people just say, well, it would be my spouse, right? And then we dive a little bit deeper into that and say, well, according to legal surrogate decision making, it would be your spouse if you didn't choose somebody else. But you do have the opportunity to choose someone who's not related to you by blood or marriage. And we talk about some reasons why you might do that. Some examples would just be from working in geriatrics for quite a long time. We have to take into consideration, is my spouse in early stages of dementia? Is my spouse also dealing with multiple chronic conditions that may be exacerbated with the stress of having to make medical decisions for me? There's lots of reasons why we may not choose our spouse, or why we might choose one child over the other. So choosing somebody that you would trust. Can you go back just a sec, Lindsay? Thank you. Someone who you believe would follow your medical decisions, even if they don't agree with them. can handle stressful and uncertain situations. And again, really letting people know that that person does not need to be related to you by blood or marriage. A lot of people that we meet with will say, I don't have any family. And then the conversation starts diving into relationship. And that again is a really important conversation, much deeper and important in my experience than do you want CPR or not. So just briefly, we do talk about who decides if you don't choose a healthcare agent. And so I won't go into this in detail, but if you are not aware of what the legal order of decision-making is in Washington State, it just expanded last year. And it's helpful and things can get complicated. So this is usually what lights a fire under people to complete their documents. Once they understand, we have to talk to somebody. And if you don't choose somebody as your healthcare agent in a legal durable power of attorney for healthcare document, this is who we would go to. And a big thing in Washington State to understand is if there's more than one person in any category, so adult children, for example, in Washington State, we have to do due diligence to reach all of your children, and they have to all agree on the type of medical treatment you do or do not get. And you can imagine that gets very complicated. So happy to talk more about this order of decision-making. Honoring Choices has created a really beautiful visual of the legal order of decision-making that we often use in clinics as a way for people to understand this a little bit more. So the question again that we often come back to is, what do you value? What makes your life worth living? What level of engagement with others is important to you? And that's both mentally and physically. So you're probably aware that one of the biggest diagnoses that cause people to be unable to make their medical decisions at end of life is dementia right now. And most documents do not cover dementia. There is an incredible dementia-specific directive released by UW Medicine, a gentleman named Dr. Gaster. Happy to give you more information if you want. But this usually is the most powerful question I can ask people is, what level of engagement with others is important to you? And what's your line in the sand? So that's explained in a lot of different ways, but I've heard someone recently say, what do you do on a daily basis that you're not willing to live without? And so you see, we've been going around about the conversation backwards. And you pointed that out, Liz, and I'm really grateful that you did, because if we start with, do you want medical treatment to help keep you alive? That's a very different question in what do you value about the quality of your living? And then how can we align your medical decision-making with that information first? So to treat or not to treat is a part of this conversation. When we get into medical care, explaining what is life-sustaining treatment, what does that even mean? What are some decisions that may come up? Most documents only cover if I am already dying or am in a persistent vegetative state or a coma. Well, I can't say all. Elder law attorneys are starting to integrate a little bit more of this other conversation into their documents, but most legal documents only cover if I'm already dying or in a coma, then this is what I want you to do. That's all that can be in a health directive. So the conversation around what you value, Honoring Choices has put into the durable power of attorney for healthcare part of the document. And again, happy to say more about that later. But what I want to point out is, according to UW, the likelihood that whoever's completing this document will be at end of life with no chance of cure or change or in a coma is a 1 in a 10,000 chance. That leaves a lot of gray area in between that we are not having conversations around. A big thing that we explain to people is that comfort care will always be provided. A big concern for people is, will my pain be treated? Will my anxiety be treated? And we explain a lot, there was a document when I first came to Peace Health that said treat or do nothing. And that was one of the first things I did, was get rid of that document, because we don't want to give the impression that either you get treatment or you get nothing. It's what's the focus of the treatment? So we educate a lot to that. What is comfort focused care? What is palliative care? What is hospice? And what might your care look like if you were not going for full-on life-sustaining treatment? So the advanced directive has two different parts: the durable power of attorney for healthcare that I've spoken about several times. That's where you name your healthcare decision maker. And the healthcare directive is where you document how you would want to be treated in certain medical situations. So again, most power of attorneys just have you name people. And then we have to hope you've had a really meaningful conversation with those people before they need to step in on your behalf. The Honoring Choices Advanced Directive includes 5 pages in the Durable Power of Attorney for Healthcare document called Preparing Your Healthcare Agent. So it answers a lot of those questions. What does a good day look like to you? If you were dying, where would you want to be? That religious, spiritual, or personal belief part. So it's not only naming people, it's what can we let these people, what have we learned is important for your healthcare decision maker to know in advance to help guide them in decision making if you're not in one of those very extreme situations that's covered in the healthcare directive. So the difference between a POLST and an advanced directive, that question comes up quite a bit, and that's kind of a seminar in itself. And we are actually doing a lot of education around this with providers and mostly providers and lots of caregivers as well. Working again in collaboration with the statewide POLST task force to create 1-hour grand rounds around POLST, creating a lot of provider tools around the difference between POLST and advanced directives. So just really briefly, an advanced directive is for people everyone 18 years of age and older ideally would have an advanced directive on file. A POLST form was intended to turn an advanced directive into a medical order when somebody is towards end of life and or has a frail medical condition where aggressive care in emergency medicine could do more harm than good. So a POLST form is intended to communicate to emergency responders it's an out-of-hospital medical order for your current state of health, and basically answers 2 questions. If you have a cardiac arrest, do you want CPR? And section B is if anything else happens and you're still alive when we find you, do you want to be taken to a hospital, and how aggressive are we getting with medical treatment on our way there and when we get there? So it's based on your current medical condition, where an advanced directive is for a future sudden or unexpected event if you're unable to speak for yourself. It is to inform emergency medicine. It does not establish a legal healthcare agent or medical decision maker. So that's one of the huge challenges. When the POLST form came out, a lot of folks were seeing it as a real short and quick advanced directive. It does not in any way take the place of an advanced directive. It's meant to take what is in the advanced directive and turn it into a medical order for out-of-hospital medical order for emergency responders. And again, happy to answer more questions around that, but this is a big part at a statewide level that we're working on currently. So you can skip this. Sorry, I thought I hid that slide. This is just some next steps when we give information about once you complete the document. Sorry, you could go back one actually, Lindsay. Thank you. Oh, sorry, forward one. Yeah, thank you. So once people have completed the documents, a big question is what do I do with them? So this is part of an advanced care next steps document that we use at Peace Health. It would look different depending on what community you're in, but basically to make sure that people know that getting these documents on file at their local hospital is super important. And that way they are accessible at times of emergency situations. So a lot of the times people will say, well, I have one, but it's in my safety deposit box or in a drawer somewhere. We are strongly encouraging people to get them on file at their local hospitals. And this is just information we give out specific to areas where Peace Health is the primary hospital on how to get it on file, how to call medical records to make sure it's there, et cetera. And then lastly, a big thing we talked to folks about, just as you had mentioned as well, Liz, is that this is not a one and done conversation. So this is a living document and it will change. So when you complete it, it's for who you are right now in the case of a sudden or unexpected event. And you want to relook at the documents every decade. If you go through a divorce and who you were married to is named as your medical decision maker, you need to look at that, because if they're named on your legal document, they are still your medical decision maker, even if you get divorced. If you have a new diagnosis or a decline in your health, you want to look at your document, make sure it's still clear. And death is if the death of whoever you've named on your document has died. You want to relook at the document and make sure that you understand that if your primary medical decision maker has died, the next person on the list is now your number one person. Quite often people don't think a lot about the second person because they thought way back when they did the document, that'll never happen, I'll just put whoever's name down. We see that quite a bit. Oh, now I'm their medical decision maker. We never talked about it. So we want to make sure that this is a living document. We're having conversations every Medicare annual wellness visit, every annual wellness visit for our younger patients. We're not there quite yet. We're kind of working mostly with Medicare patients at this time, and really reviewing these documents on a more regular basis. So lastly, I would just say a lot of as you can imagine, when I stepped into this job, I was thinking, where on earth do I begin? There's so much work to be done. And this is 5 promises of an advanced care planning system that was created by Respecting Choices out of La Crosse, Wisconsin. And I use this a lot to guide my work. And what are we doing around these promises? Promise 1, initiating the conversation. Promise 2, providing assistance with advanced care planning. Promise 3, making sure the plans are clear and up to date. Promise 4, maintaining and retrieving plans. So a lot of the work we do on the medical system side of things is make sure these documents are kept in an easily accessible place in our electronic medical record, and that everyone knows where to find them, how to retrieve them, how to interpret them. And then the last promise is appropriately following the plans, whether someone ends up in the ER or the ED or the ICU or wherever they're receiving care. Are these documents being looked at? Are they being appropriately followed? And what are our barriers to that? So I would just say that this work would not be possible without the collaborative efforts of our community partners. And I have been incredibly honored to work with Marie Eaton, and will soon hand the microphone over to Marie. Marie is the community champion for the Western Washington University Palliative Care Institute. She's also the chair of the Northwest Life Passages Coalition. We have a smaller group within the Northwest Life Passages Coalition here in Whatcom County called the Advanced Care Planning Task Force, where we bring all of our partners who are working on advanced care planning in many different levels and talk about what are you up to, what classes are you doing, how can we collaborate our efforts a little bit more. So even though I work within the medical system, I often meet with Marie and several of our partners in the community and just say, does this make sense? Is this serving our community? And how can we continue to work together in these efforts? So Marie Eaton, take it away. Thank you so much for your time.
Okay, thank you, Hillary. That was a wonderful summary. So if you could go to the first slide there. So I want to talk a little bit about the community side of creating a healing and caring community of excellence. And this slide says that I'm the director of the Palliative Care Institute. I should have changed that. I'm now the community champion. The director is Devyani Chandran. So I'm going to talk a little bit about the development of the Northwest Life Passages Coalition, which brings together a variety of players in serious illness and end-of-life care in our community. And then talk in particular about the Advanced Care Planning Task Force that's part of the Northwest Life Passages work. So the Northwest Life Passages Coalition came together out of a initiative that the Whatcom Alliance for Health Advancement started in 2014. And these are some of the members that serve on that coalition. And our goal is to create a community of care and support for patients with serious illness or facing end of life. And you can see that, back 1 minute, Lindsay. I just want you to notice that although some of the players are people in the medical systems, there are also people in this coalition who come from community agencies serving people with serious illness and other kinds of support people, including some community representatives. Thank you. So our goal was to try to were available. And what we noticed was that although Whatcom County had a lot of services for seriously ill or dying people, often those were uncoordinated, sort of like all the little boats in the upper part of the picture. And our goal in the coalition is to get all the canoes rowing in one direction, that we come to some consensus about what services need to be provided, and to do a better job of collaborating and sharing resources across our various agencies and programs. So this is if you keep clicking, it'll come on. Okay, so first we convened the task force in 2014 to ask the question, what would it take to transform Whatcom County into a center of excellence for end of life? So we explored those existing resources, and as I mentioned, we found that as we looked out across the community, we found that there were a lot of resources available, and we particularly focused on advanced care planning, palliative services, and community understanding. We identified the gaps in areas of need. We wrote a blueprint to guide improvement, and then revised that blueprint in 2017. And these are the 5 blueprint pillars. And I'm going to spend most of the time talking about the advanced care planning pillar, but to allow you to see the context that that advanced care planning work takes place in. So obviously, we wanted to make sure that the clinical care that's provided is excellent clinical care in the inpatient setting and in hospice. And then we've begun an outpatient initiative to try to cover that gap for patients who are not yet eligible for hospice, but would prefer to be at home rather than in an inpatient facility of some kind. We also focus on provider training, and Hillary has talked a little bit about the ways that Peace Health is doing training with clinicians, and the Palliative Care Institute also sponsors conferences and trainings for clinicians. A really important piece of our work is community activation, because like the changes that happened in birthing practices in my youth, these changes in the way we approach serious illness and end of life will not happen from the medical side alone. It's going to take collaboration between both medical providers and community partners to actually make the kinds of changes that we're hoping for. And then finally, looking at sustainability, meaning what are the kinds of legislative, financial, be taking place in order to fund these kinds of programs. So if we look at the advanced care planning pillar, and there are multiple programs happening in our community. And so Peace Health, as Hillary said, they have a very robust advanced care planning program now since Hillary's been on in the community. The Northwest Regional Council, which serves 3 counties, it also is doing community-based advanced care planning work. There are other community programs, and the Palliative Care Institute is also providing support. So I want to come back to what Hillary mentioned earlier about having the importance of having a serious conversation about what gives people value. And this Institute of Medicine study from 2015 has really guided the kind of work that I am trying to do in the community. So when older patients with advanced serious illness were asked what their priorities were, this was in their priority order. They want to live independently as much as they can. They don't want to be a burden to their families and loved ones. They want to have their symptoms managed, so they want to have their pain and anxiety and breathlessness and managed. And last is to live longer. And without an advanced care plan, usually that is, live longer is the initial instinct and impulse of the medical profession. So we are able to do things to keep people alive often longer than they want to be alive. And without a good advanced care plan, that's going to often be the default. We keep you alive no matter what. So as I mentioned, the Northwest Life Passages Coalition pulled together an advanced care planning task force. And the initiative, the instinct to do that came from this very thing that Hillary referenced in her presentation. We noticed that the community was using multiple kinds of documents, that there was very little conversation between the medical professions and the legal professions about advanced care planning, that the places and venues in which advanced care planning was happening seemed to be fairly random. So some clinics were actually doing advanced care planning work with patients at Medicare visits or in other settings, but many of them were not. And so we tried to bring together as many people in our community who are willing to come to a monthly meeting to talk about our current advanced care initiatives. So we have representatives from Peace Health, from the Family Care Network. We have invited CMAR and Unity Care, but who has the time to come. But we're trying to find venues to share the information that we do. We also have representatives from the Northwest Regional Council, from community members that are doing advanced care planning plus dementia work. We have a very interesting community program in our neighborhood called the Realities of Advanced Care Planning, which provides community members with more understanding about what CPR actually means when you are a frail elder. Most of us who watch Grey's Anatomy or some other hospital-based television program might think that CPR works 80% of the time, but as you may very well know, the realities of how many people actually come back to full function after CPR, the percentage is much, much lower than that. And so for me to make a decision as an older woman about whether or not I want CPR, I need to understand what the likelihoods are that I will actually come back to the functioning that I hope for. There's another advanced care planning program called Speaking of Dying, and we have some practitioners of that work in our community. And we also work with the Health Ministries Network that is using parish nurses in their communities to do advanced care planning. And part of, okay, I think the next slide. So part of our goal is to do, in the task force, is to coordinate better the advanced care planning that is happening in our community. So some of the things that the task force has worked with Peace Health on is, as Hillary said, the early work of the Northwest Life Passages Coalition was to negotiate that our hospital, which we are a one hospital county, that our hospital would store all advanced care plans for our county, even if the person is not seeing a clinician at the hospital. We also helped influence them to make sure there's an ACP tab on the EMR home screen. And then Hillary is obviously engaging in robust training for personnel in the ER and the EDs, so that as patients come in, we are hoping that their plans will be accessed. Next. So as I said, we have also built some agreement on the forms and processes. So most of the people in our community now are using the Honoring Choices Pacific Northwest form, or that form in collaboration with some other processes. And we have done lots of community education activities. The picture there on your, we did a back of the bus campaign. One of the challenges around advanced care planning is that people are reluctant to talk about their own dying. We are kind of a death phobic culture, and for some of us, we think if we start talking about dying, perhaps we're calling death toward us. And so we are trying to do a lot of community activities to get people to engage in the conversations about their choices at end of life in both serious workshops, but also in some other kinds of perhaps less intense conversations. We are working on a hardwiring task force to bring together people who are in medical systems and in other systems that see patients who are seriously ill or facing end of life, to see if there are points in our normal intake and processes where we could make sure that we are engaging the conversation about advanced care planning. And that task force will be meeting in March in order to begin that conversation about where are the logical points in an intake process for perhaps it's an intake process for housing for an elder. And one of the questions that might get asked in that intake would be, do you have an advanced care plan? And then we are also planning a countywide survey on advanced care planning completion in collaboration with the health department here in Whatcom County and with the Northwest Regional Council, to begin to see if we can tease out a few more of the kinds of barriers that might keep people from completing an advanced care plan, and see if we can't get better data on how many plans have actually been completed. Next. So I guess we're at a place where there could be some questions and answers.
Yeah, thank you, Marie and Hillary. That was great information. And at this time, we do want to go ahead and open up some questions. And if you all have questions that come up, please chat them into the Zoom chat box. I'll give you a couple minutes to get that started and get your questions entered. In the meantime, while you're entering your questions, we do have some resources that we want to share. And Marie or Hillary, I'm just wondering if you can speak a little bit to these resources here. We'll also send these out after the webinar with a link to the recording. So if you don't get it written down now, you will have it later.
This is Hillary. I'm happy to speak to, if you go back one, just on the resources. So we have created a Peace Health website for advanced care planning. We have lots of frequently asked questions on that website. There are links to the most commonly used documents in Alaska, Washington, and Oregon, because Peace Health serves all 3 states. And we have a link so that folks can register to our regular monthly classes, which are called Your Voice, Your Choice, where we walk people step by step through completing their own advanced directives, and we bring a notary to every class so that people do have the opportunity to complete them. It's a really, really engaging workshop, and they're offered twice a month in Bellingham, once a month at United General in Cedar Woolley, and quarterly out on San Juan Island. And all of that information is on the Peace Health website. The Conversation Project is just, if you don't know about this organization, they are an incredible resource for how to initiate the conversation around advanced care planning. They have lots of conversation guides that you can download for free. I believe they're in multiple languages, definitely Spanish and English. And they have lots of really funny videos that you can show if you're ever leading a workshop related to advanced care planning. Of course, as much humor as you can bring in it to kind of lighten the topic a little bit is helpful. And the next page, Lindsay, has a connection to the Washington Post form and some frequently asked questions around Post, and the Washington State Medical Association document. Again, that's the most widely used document in Washington State. We're currently working to either replace this document with a more values-based document, or at least rework it, because it's at a college grade reading level. It's hard for people to understand exactly what it means. And I call it the get or done document because, again, it only has you name people and then speak to those two pretty extreme medical situations. And then Honoring Choices Pacific Northwest is a great website. You can download the document that we've been talking about on that page, as well as get connected to a whole bunch of resource information that's happening across the state.
So if you go to the next page, so I included the Palliative Care Institute website if you want to see some of the other community-based activities that we're doing and the provider education things that we're doing. And then if you want to dive deeper into the blueprint, so not just to see what the pillars are, but to read about how we did it, and there's a link there to access the blueprint.
Are there questions coming in?
Yeah, great. Thank you so much, Marie and Hillary. There is one question that's coming in, and that is from Mary O'Leary, and her question is, what languages are you hoping to translate the documents into?
This is Hillary. So we're currently working on revising the Honoring Choices document and or adapting a document that has already been used across the country called Prepare for Your Care. I don't know if you're familiar with that document, and there's a lot of conversation about what would best serve our residents in Washington. But once we come to that decision on how to revise the document, make it a little bit shorter, a little bit more user-friendly, I can't answer exactly what languages we're planning to translate it into, but I can tell you for sure Spanish, Russian, Punjabi, and Vietnamese are the 4 priorities for the populations that we're serving here at Peace Health. So those are the languages that we're bringing to the table. There are many other languages out there that we see on a regular basis. I currently work with a translator when assisting somebody with advanced care planning who doesn't speak English, but that's quite challenging, as you can imagine. So stay tuned on what languages we're planning to translate the documents into. As you may be familiar with the 5 Wishes document, that's already been translated into multiple languages. There's a reason why we're not shifting to use of the 5 Wishes document. Happy to talk with anyone offline about that. But if you have any suggestions of really languages that you would strongly like to be put into the mix, then please feel free to email me.
Yeah, so this is Liz, and I think Hillary, early on, you asked this question about, like, are there other barriers or other things that kind of get in the way of people doing this? And I was just going to share a couple of thoughts from my work in Oregon. So these are a couple of comments, and then I probably have a question for either one of you. One thing is that people still equate advanced care planning with, number 1, you're really, really old, or 2, you're really, really dying, as opposed to thinking about the fact that, unfortunately, one of the byproducts of having such an incredibly highly skilled health system is it's really hard to die sometimes. Yeah. So it is how do we pivot this from it's about dying to it's actually about who gets to make the decisions about how you're going to live out the rest of your life. And so that's one piece I think that's been really significant in the Oregon conversation. And then the second is really, how do you get people in their 30s and their 40s to also realize, guess what? Things happen to you when you're young as well. And, just the pivot in those conversations, it has changed, some really simple things like who's on the cover of the discussion guide on the materials in Oregon, to, we've had some conversations about, I wonder if every student entering the university system in Oregon should have an advanced directive put in front of them and a discussion guide. Like, we're really trying to figure out how, because what you think about life and what you would want somebody making decisions for you about are really different when you feel invincible than when you feel frail, and all of the stages in between. So I appreciated the 5 Ds as you were kind of walking through that. But, you know, I'm curious if the work in Washington is both thinking about that pivot to who gets to make decisions about how you live.
This is Marie. So I'm happy to begin the answer. Hillary probably will have things to say as well.
Yep.
But we are absolutely thinking about how do we make sure that these classes and this work is not only being done with those of us who are 55 and older. We've done, for the National Healthcare Decisions Day, we do robust outreach with younger people and have done a couple of events that are particularly targeted at younger people. We did one a year or so ago where a community member raised enough money to offer 5 $1,000 scholarships, and we got a ton of students from our local colleges who came to participate in a drawing, and to get to the drawing they had to sit through a conversation about advanced care planning and its importance to not only to older people, but for all the reasons you just said. How do I want to live my life, and how do I want to make sure that if I can no longer speak for myself, someone is making the decisions I would like to have made? And many of the students at the end said, I came only because I wanted to have an opportunity to be in the drawing for the scholarship, but I now know that I want to do a plan myself, and I want to go home and talk with my parents about what their decisions are. So I can see that this conversation is important to me as well. Another initiative that we're doing this spring is for National Healthcare Decisions Day. We're going to try to use some humor, and we've engaged an improv theater group to do an evening of improv about all the kinds of crazy things that can happen if you don't have a plan. And we're hoping that that will also attract a younger crowd, and a crowd that we don't typically engage when we are just offering a seminar on advanced care planning. Last summer, we did a theater series where there were 3 plays in our summer repertory theater. All the plays had a person with a cancer as a major character, and the Palliative Care Institute did talkbacks after those plays, and that pulled in yet another group that we haven't ordinarily reached. So we're trying to actively think about the ways that we can pivot that conversation.
So I have another question, and I'm milking this. I'm new to Washington for probably more years than it's worth, but and it has to do with the post and EMS. And so again, just kind of using a scenario that I came up against a lot in Oregon, where caregivers might call 911 because they are in a panic. Mm-hmm. And there is just nothing more traumatizing to a caregiver than to watch somebody who they know is frail and dying go through resuscitation, CPR, and all of a sudden they are so regretful of the fact that they called 911, but they didn't know any other thing to do. So when you're in a panic, it's what we have kind of ingrained in our heads. And so in Washington, if there is a post, and it's sitting on the refrigerator where we always told everybody, like, keep that fluorescent colored thing sitting somewhere, will EMS follow the orders of a post if they're called to a home?
So this is Hillary. I can say that yes is the short answer. They will absolutely follow a post. There is an exception, and we're doing a lot of work with EMS right now and finding out what their barriers are to following documents. If a family member, so this happened in my family, my uncle was a do not resuscitate, very, very clear, had a post form or whatever it was in the state where he lives. And he had a cardiac arrest. His partner called 911, and the EMS showed up, and they said, your husband has a DNR order. This is what is going to happen. And his partner went against his post and said, absolutely not. I am not ready for him to die. I want you to do everything you can. And they did CPR. He ended up in the ICU for about a week. And then my uncle and the rest of the family had to make the decision then to withdraw treatment. So very important as we're doing the post education to make sure that all of your family members are on board and they don't go against what you've written in the post. So that is one barrier that EMS is bumping up against. But by all means, if they show up at a house and there's a do not resuscitate order and the family's on board, then they will follow it. And they're doing a lot of training with their crew on what does that look like? How do we go to a home without the sirens going crazy if we know that person is a do not resuscitate, which brings up a huge challenge in Washington that you had the benefit of in Oregon is the post registry. We do not have that in Washington state. So EMS, the only way currently that they know if that patient whose home they're going to has a post is when they walk in the door and see it on the fridge. So we're working on that at a statewide level, and Oregon is way ahead of us on that realm and would be incredibly helpful. But if they see a post, absolutely, they will follow it, with the exception of a family member pushing against it otherwise. Does that make sense?
It does. And, you know, and I just think that there's being a part of some of the education, you know, both for family members, but also for fire and EMS. Because it's really hard when they're, you know, come plowing through the door trying to save somebody and the family is at odds. And, you know, so some of the earlier remarks of, you know, having family is awesome. Having family that are in disagreement about what to do when those situations come up, it forces the emergency responders to always err on the side of resuscitate, which just made
right.
it. And
I want to say that the director of EMS is a member of the Northwest Life Passages Coalition here in Whatcom County. And so he's engaged with all these conversations, and it's been a really important part of our planning together.
Great. So probably my last question is if either one of you have any ideas about, since you're both kind of based somewhat here in Whatcom County, how do we make this a region-wide conversation?
Well, I would encourage whatever county you sit in to the Northwest Life Passages Coalition process is one that could be replicated in any community. And I mean, each community has its own unique features. And so I don't think the blueprint we wrote is immediately transferable, but to have that bringing together the players who can collaborate strengthen the work in our community, and both at the macro level in the coalition and in the micro level in this advanced care planning task force. So there was a lot of advanced care planning work going on, but it was pretty fragmented and actually quite confusing to the community. And pulling together the group of people who are working on it in your home community can help you focus and build on the strengths that each part of the program has, rather than showing a fragmented approach.
Yeah. So you're actually, it sounds like you're saying you can't imagine that happening at a regional level.
I think what the that is, I think there are things in each community that work. For example, we are a one hospital county. That's not true of most counties. So some of the solutions that we've found are based on the fact that we only have one hospital. So I don't think it can just apply regionally, but the process of doing it could be a regional, supported regionally for each community.
Mm-hmm. I would also say collaborating with Honoring Choices Pacific Northwest, if you're not already, would be a great next step, because they are the statewide initiative who is working on creating advanced care planning conversations, both at the community level, training facilitators, training people to be able to have these conversations at the community level, as well as medical system groups. And you know, Peace Health is is in collaboration with Honoring Choices, as well as Providence Medical System, Confluence Health, Olympic Medical out on the Olympic Peninsula. So there are already a lot of medical systems already engaged in Honoring Choices, and we meet on a monthly basis and talk about what's working, what's not working. So they have a clinical education team that's working on serious illness conversation training. They're creating the Pulsed Grand Rounds, which we're piloting at Peace Health and Olympic Medical, but will soon be available for across the state. So Honoring Choices Pacific Northwest, I would say, is really the collaborator of a lot of this work across Washington State, and happy to help you make that connection if you haven't already.